Hello and welcome back to the podcast. My name is James Waldron, GP and GPnotebook podcaster and educator. And this is part 3 in our 4-part series exploring HIV in primary care. And today we're focusing on prevention, PrEP and PEP, what they are, who they're for, and why they matter in everyday general practice. And we're once again joined by the brilliant Dr Grace Bottoni, Lewisham GP and HIV and Hepatitis champion. And this time we're also welcoming Dr Emily Mabonga, consultant in HIV Medicine working in London. In this episode, we're diving into how GPs can support patients with HIV prevention, from normalising sexual health conversations to knowing when and where to refer for PrEP. It's a really practical discussion full of insights for busy primary care teams. If you've missed the first 2 episodes, we covered diagnosing HIV and what to do after that positive result. Definitely worth going back for a listen if you haven't already, but for today, let's get started. Well, I think first of all, coming to you, Grace, you've made this possible and been the link to all of the consultants that we've got speaking today. Can you tell us a little bit about your role and a bit about the background in this topic?
So I've been an HIV champion in primary care for around 4 or 5 years now, and I started off working on the social impact bond that was funded by the Elton John AIDS Foundation. And we were trying to increase HIV testing in the emergency departments, but also in primary care. And that work, together with other work that my colleagues have been doing, has led to the HIV opt-out testing in emergency departments that we see now around in England, and hopefully being expanded throughout the UK. And I don't know if many people know that the UK government released an HIV action plan back in 2021, and the priority is to end new HIV transmissions by 2030. And one of the ways is through the opt-out testing in the emergency departments. But also, we have been very lucky in London to have several HIV GP champions whose role is to promote and raise awareness about HIV and HIV testing, because a lot has changed in the last 30 to 40 years.
Yeah, absolutely. And I think it's great that primary care and secondary care have got this link, and to have GP champions, and it's great that they're in London. I'm hoping they can spread all across the country as well. And for anybody out there that's interested in doing this, I really hope that these podcasts will stimulate your interest in it and be able to bring better services to people across the country. So you mentioned a lot about that is the opt-out testing, but some of this is about PrEP and PEP, and I think this is how you've got in touch with Emily. I'd like to take this opportunity to bring you into the conversation. Emily, welcome. Would you like to tell us a little bit about your role and the expertise you're going to bring today?
So generally, I trained in GUM medicine at King's, and I have been working in Lewisham for 8 years now. Lewisham and Greenwich, London have some of the higher rates of HIV prevalence. I think Lewisham were at number 8. Number 1 and 2 are Southwark and Lambeth. So HIV prevention is really paramount to what I do. But not only that, but HIV treatment, because obviously, as Grace said, if you get a test in A&E and you're positive, someone has to put you on treatment so that you don't transmit the virus. So that's one of the strategies we have to getting to zero. So ED testing, so you can find people and treat them. Then you've got PrEP, which we will talk about, where you can give people treatment to prevent HIV, as well as PEP.
Oh, wonderful. I mean, certainly a pretty fascinating topic to explore. And we were talking about these sort of picking up cases and the overall HIV consideration across the country. And we're going to explore that on another podcast as well. And we're really focused on PrEP today, which is really exciting because I think quite a lot of GPs are not so well versed in this. It's not something they understand so well. Bring you back, Grace. Why is this such an important thing for us to talk about? And why is it so important in primary care?
Well, as you mentioned, I think not many people know about it because it's not something that I was taught in medical school or on GP training. And PrEP, for those who don't know, stands for pre-exposure prophylaxis. and Emily will talk a bit more about what it actually is. But it's essentially bread and butter of primary care because it's a primary prevention. So I sort of would compare it to something like a statin that we give to patients to prevent them from developing a heart attack or a stroke in the future. So PrEP is something that we would offer to patients to prevent them from acquiring HIV.
Mm.
And yes, it's something that we need to talk about. So we need to educate our primary care teams, but also educate our patients because not many patients know about it. So if you don't know about it, you can't really ask for it.
Yeah, and I think that's really important. If GPs don't know about it and we don't understand about it well, how on earth are we meant to encourage our patients to access this, essential care, isn't really?
Exactly, exactly.
Mm. So, okay, so we've understand the importance of PrEP. So, I suppose coming to you, Emily, what is it? What are we actually talking about when we're talking about PrEP as a thing?
So you both stressed it. It's a prevention. So PrEP is about prevention, and PEP is also about prevention. So I always use analogies. I always use analogies that people know about. So emergency contraception. If someone came in having unprotected sex within 72 hours, you would obviously say, "Oh, you need emergency contraception." So a similar analogy for PEP. Or so if someone had unprotected sex, or even actually if you had a needle stick injury within 72 hours from somebody who was at high risk potentially of having HIV, you'd be able to offer PEP. PEP or Pep C if it's a sexual exposure. And it can be taken within 72 hours. They're tablets, which we use to treat people with HIV, and you take them for 28 to 30 days. Job done.
Yeah.
And then PrEP. So PrEP to me, another analogy is like regular contraception. So you give it to, if someone's coming in, they're in a new relationship, you say, oh, let's just start putting you on the pill. So they say, oh, what's your pill? Well, I'll go on microgynon, I'll take microgynon for 30 days, etc. So that's exactly what PrEP is. It's before the act. So it's taking the medication, so taking a tablet, depending on how you're going to dose it, which we'll talk about later, but it's taking a tablet every day or on demand to prevent getting HIV. So I see it similar to just regular contraception. Giving it before the event, PEP is giving it after the event.
And thank you for sharing that with us. I mean, I think for a lot of people that are a little bit unsure to what this incorporates, using that analogy is really, really useful. The idea of prevention, and we do so much prevention in primary care that it's a thing that we shouldn't be scared of, I think is what I take away from that. So we're thinking about when we're using it. So how do we determine who might benefit from that?
So we did have, we all have guidelines, and we did have guidelines to assess those who were most at risk and those who were less at risk. And actually, the current guidance is actually saying if somebody wants it, they should have it. You should offer it to them because we really don't know what someone does at home. We really don't. So I think if somebody does come to you and ask for PrEP, so this is like the regular contraception to prevent HIV, you should be able to signpost them to our services to offer it to them. But other times, you're so lucky as GPs, you get to see, you have undifferentiated clinics, don't you? You see everything. So if someone comes in and says, oh, they're going to be traveling abroad, or they're potentially have confided to you that they're a sex worker, or actually if you've managed to, if you did see a gay man and you did diagnose rectal chlamydia, there are certain risk groups that actually you should be having PrEP at the back of your mind and saying, oh, have you ever heard about PrEP? Because chances are, particularly in women who you probably see more of than I do, who might potentially be at risk, or they've got a new partner, they're going back and forth abroad, you have the opportunity to say, oh, by the way, have you heard of PrEP? But actually, if someone does come to you and ask for it, please offer it to them, but do it at the back of your mind. Think of people who potentially might be at risk of getting HIV, and just have a conversation with them just to let them know, that there is something out there that can prevent you getting HIV. Like it's someone who comes in with multiple partners, you say, oh, you probably need to go on the implant, or, take the pill. So just looking at it like that just takes the edge and tension out of things.
Yeah, well, I think that's a very helpful angle to come at this for. But of course, those conversations can be quite difficult to bring them in. I mean, Grace, because obviously you straddle this line between the HIV world and the primary care. Have you got any thoughts about how we might sensitively bring this up in conversations, and the realities of having those chats.
Yes, I mean, this is something that comes up time and time again when I speak to GPs and other members of primary care teams, that people feel, awkward talking about HIV. I think part of the reason is that talking about sex can be quite awkward, especially for GPs who maybe have known their patients for many years, know the ins and outs of their relationships or their lives. And yes, talking about sex can be awkward. There's no doubt about it. And it's probably because we don't do it enough.
Mm.
But studies have shown that patients do want to talk about sex, but they often wait for their healthcare provider to bring it up.
So
So we're
right.
in a yeah, so we're in a bit of a catch-22. Um, so I mean, as Emily said, PrEP is really for anyone. I think we sometimes get it in our minds that PrEP is only for men who have sex with men or people that attend sex parties, and that's just not the case. It's for anyone who has sex without a condom and doesn't know their partner's HIV status, essentially. That's where we encourage people to know their status, and if they don't know their partner's status, then to take PrEP. So as Emily said, think about opportunities to discuss PrEP. We're not saying, oh, you need to offer it. If someone comes in with a toenail problem, you should talk about PrEP. I mean, that's not what we're saying. But if someone comes in about contraception, or they've worried about an STI, or they're starting a new relationship, or like, they're traveling abroad, and as the same way that we would offer them vaccines to protect their health, we would say, have you considered protecting your sexual health? There is something called PrEP that is free and that it reduces your risk of getting HIV. Would you be interested in knowing more? So opening up that conversation, if someone says, "Oh no, doc, I'm not like that," or "I'm not interested," or "Why did you bring something like that up?" And which I think a lot of GPs do worry about, that they might offend someone or make the conversation difficult. But starting that conversation, if they don't want to talk about it any further, that's absolutely fine. You At least you've told them about it, and you just move on. But if you leave that door open, if they do want to know more, you now know from listening to this podcast what PrEP is.
Yeah.
And there are some websites that you can direct patients to that we'll leave in the post and the podcast notes. And you can get some free leaflets to have in your reception and your waiting rooms. So yes, it's just sharing the knowledge and educating our patient populations. So that's really important. Why we need to bring this up in conversations.
Yeah, I absolutely agree, and I think that it's good to acknowledge how difficult this is to bring up for both the patient and for the clinician as well. As you say, we're not necessarily taught how to talk about sex in in medical school or even in GP training, but it's something we get asked about an awful lot, isn't it? So I think getting practiced at it and sort of normalizing that conversation. The other thing I'd sort of pick up about that is the question about people not knowing their HIV status, and that links in quite well into one of the other podcasts that we're doing about screening and about trying to figure out what the impact on particular populations is. So it cross links these messages, isn't it? So we've talked about bringing this conversation up and trying to raise the issue with people. So we've referred them, and they're going to come and see you, Emily, or one of your colleagues across the country. What's that consultation look like?
So the first thing is just as Grace says, remember it is free. They do not need an ID. They do not need a national insurance number. They do not need a council tax address. We do not need anything from them, but for them to attend. So it's absolutely free, because I think a lot of people, that's a barrier. So if they're concerned that, oh, my immigration, they might be asylum seekers, it's absolutely free.
And it's wonderful to hear, because I can quite imagine that people will come from health systems where they have to pay for every single medication, or the stigma or worry about that is going to be a major barrier, and we need to break those down to help reduce transmission, of course.
No, absolutely. So, and it's absolutely confidential. So and yes, we do not share the details with the GP unless they asked us to. So, when they come into clinic, as I say, we're an open access service, but I do know that there are some services where they only have appointments. You can only book an appointment online or on telephone. So you just walk in, have a conversation. We assess, how many partners they've had. We assess their knowledge on PrEP. And essentially, as I said, now if someone feels that they are at risk of getting HIV, we offer them PrEP. So what is PrEP actually? We talked a lot about PrEP. What is PrEP? So in the UK, we have 2 tablets that we use for PrEP. Commonly, one's called tenofovir emtricitabine, which was made by it was made by one of the pharmaceutical companies, but it's got off patent. So it's actually pretty affordable for the NHS. And the other one is what I sort of call PrEP Light. It's called Discovery, and in it's got a drug called TAF and emtricitabine. So the reason we've got this light PrEP is because of potential side effects.
Okay.
Yeah. So the first one I talked about, tenofovir emtricitabine, we've been using that in combination with a third drug to treat people with HIV for over 25 years. It came into actual treatment guidelines in 2001. So we've actually used it in people living with HIV, and we've got very good knowledge of it, and it's really, really safe. But when you do studies, it did show a decrease in the bone mineral density in participants who were on it more than those who weren't, and it did show in those who had kidney impairment, renal impairment, it was probably not the best drug of choice. So that is why now we have PrEP Light as an option, but the vast majority of people are on tenofovir and emtricitabine. There's other things coming up in the pipeline, but I will talk about those later.
Yeah. I think it's really helpful to know that there are different options out there, because I think that when people go looking for medications, or if they're Googling things about this, they're worried about, like, is this just new medication? Well, actually, no, it's been used for a really long time. We know a lot about it, and that's reassuring for both the clinician and for the patient. You mentioned side effects as well, and this is particularly important for us in that initial conversation, because a lot of what will put people off is the worry about side effects. And I think, for good or for ill, in my head, it's a thing that we need to think about. Actually, if you have PEP, you're going to get lots of side effects. Is that the case? What would patients expect?
So a lot of people who have used Dr. Google and come in to see us will ask about the bone and the kidneys. That's the first thing they'll ask about. But actually, those are long-term side effects, and as I said, really relatively rare. So commonly, within the first few days, some people experience some bloating and nausea. But as I said, the vast majority of people that I've given PrEP to absolutely tolerate it well. But yes, long term, in some people, there might be a reduction in bone mineral density and kidney problems. So we do monitor. We monitor patients regularly in terms of checking their renal function. If they're under 40 years old, we'll check their renal function once a year. If they're over 40, we'll check it twice a year. The thing about tenofovir, what it does do is it just, gosh, it was a long time since I did physiology, but the glomerulus and making it a little bit more porous, and then release, you'll just release a lot of protein. So you get a proteinuria with a normal renal function, essentially. So we do the urine, and we do monitor this. And in all honesty, if you brought your patients to PrEP to have PrEP with us, we will be doing it. We wouldn't ask you to do it.
Yeah. Okay. And it's also helpful to know, just thinking about, I suppose, partly knowing that if we dip the urine and they've got protein in it, that there's a potential reason for it, but actually helps to know that the GU clinics take sort of ownership of that monitoring. And certainly in London, is that generally the case across the country as well?
Yes. So because actually PrEP can only be provided in level 3 GUM services.
Okay.
So if you have a little clinic that just does contraception, please don't send your patients there. PrEP is provided in level 3 GUM services. In fact, it's also moving into the online space as well. Watch this space as with a lot of things. But the monitoring is genuinely in terms of sexual health screening, because in London we have Sexual Health London, which is an online platform where people can actually do the testing themselves. We do encourage people who are asymptomatic to test online, but they will come in for their PrEP. And they'll also come in, as I said, for their renal functions, vaccinations. But usually when they first come and see us, we would do all the STI testing, check up on their vaccination status, do the renal monitoring, etc.
And in the show notes, we will put the link on the NHS website on where to find your nearest sexual health clinic. And there you should be able to find details of if the clinic provides a PrEP service.
That's brilliant, and especially from sort of patient empowerment point of view. And I suppose thinking about sort of the normalising this conversation, and it's good to know that the monitoring's done in GU. Is there a future for this in primary care? Is there any consideration of the future of this coming in, Grace?
I mean, that's a very good question, because one of the barriers that we found for PrEP is that they don't really want to go to sexual health clinics, because unfortunately there is still a lot of stigma around going to a sexual health clinic, particularly in older people or people of certain ethnicities. So the government is exploring opportunities for making PrEP available in different settings, such as pharmacies, but also primary care and GP practices. There are some pilots that are going to take place, but I do want to emphasize the fact that we do need to make sure that there is a balance between obviously improving access, but of course not increasing the workload in general practice. So our goal should be to increase awareness and ensure that we reach equity and access across all of our patient populations.
Yeah, I mean that sounds like a wonderful goal to have, and it's so great that a lot of this happening in London, which of course there is, as far as I'm aware, like a bit of a higher density of HIV than across the country, but there still is, there still are definite populations across the UK. So I really hope that people will feel, I mentioned this at the beginning, will feel inspired by today's talk and this series to try and improve things in the local area too. So yeah, I hope that's one of the outcomes of this as well.
Yes, definitely. No, and in the show notes, I'm going to put some links on how to find PrEP locally, but also where to download some posters and leaflets that you can use in your surgeries as well.
Amazing. Wonderful resources there, I think. Sure. So, okay, so we talked a little bit about different types of PrEP light, some of the side effects as well. What's the sort of the expectation for taking PrEP? Is this something that you would do for life? Is this a thing that is just at certain points of a person's life? And I suppose, how do we, if we're starting people on this, how do we stop?
So that's a really good question. So the thing with PrEP, it's like emergency it's like regular contraception. When you feel at risk, you take it. When you don't feel at risk, you don't take it. But the interesting thing about PrEP is there are different ways of dosing. So for those who have regular risky sex, they can take it every day. So that's what we call daily dosing. But there are those who don't have regular sex, and maybe they will have sex when they go on holiday to Amsterdam, say, once a month or once every 3 months. So you don't really want to be taking a tablet every day for just that weekend once a month or once every 3 months. So with that, you can actually take it what we call event-based or on-demand dosing. So that would be you load yourself up with 2 tablets 2 to 24 hours before you're at risk, and then take it every day you're at risk, and then for another 2 days. This event-based is mainly for people who practice anal intercourse. And we sort of say for the frontal or vaginal sex, the lead time before the drug starts working is 7 days. So it's important to know about lead times as well. And then after the risk is over, you stop it. You take it for another 7 days before it stops. They're looking to potentially change the guidance to vaginal frontal sex, where you can load yourself, take it when you're at risk, and then wash out period for 7 days to take it. So, but it's suffice to say that there's different ways of taking it. You don't have to take it forever. You can stop and start when you want to. But the most important thing is to if you decide on a regimen, to stick to that regimen. And I mean, I think what's probably important for my colleagues in primary care is just letting people know that they've got different ways of taking it, because there could be some patients who really don't want to take medicines all the time, and you can say, well, actually, you don't need to take it every day. There's ways you can dose it when you feel when you're feeling at risk than not. So I think it's a good thing to have. So if you're having a discussion with a patient, you have a good view of what the offer is.
Yeah, I mean, so I think that is a key message for primary care, that there are different ways of taking this. I suppose a question I would have about this is, with those different ways of taking it, what's the sort of effectiveness of using PrEP to prevent HIV transmission?
So the PROUD study, which was done in the UK, that looked at 554 gay men who were having unprotected sex, and they took it daily. And they randomized people to either start PrEP or deferred. And they had 3 positives in the immediate arm and 20 in the deferred. So the study was stopped because they could see it worked. So it actually had an 86% reduction. So this is daily dosing, England, UK data, PROUD study.
Brilliant.
IPerGay was done in France, and this looked at 400 gay men and transgender women, and they were randomized to either take the event-based or on-demand, which is 2 pills 2 to 24 hours in advance, and 1 pill after 4 hours after the last exposure versus nothing. And they also found an 86% reduction in those that were randomized to take the event-based. So so those are the 2 regimens that we have good data on, and we know that it works if you take it.
Wonderful. I mean, that's an amazing reduction, and it's good to know those studies, because I think people will worry, or at least have questions about, do I need to take this every day? What's the consequences of me doing it in a different method? So the PROUD study sounds very helpful. It's really good to know that there's that evidence there, and that people have different ways of taking the medication, because that's certainly something they're going to ask us about. And I suppose you mentioned about when people feel they don't need it any longer. A question that sort of springs to mind is that if somebody became in a relationship with somebody that is known to be HIV positive, and they don't have any other sexual partners, do they still need to continue with PrEP, or is this a point in which we would stop?
So this is where this amazing statement, "U equals U," and I'm surprised at how many people don't know this. Undetectable equals untransmissible. So if an HIV positive person is on treatment and has an undetectable viral load, they cannot transmit HIV to their partner. So I've had couples coming and saying, "Oh, what do I do?" And I'm like, as long as your partner is taking treatment and is undetectable, you do not need to be on PrEP. In fact, if they wanted to have a baby, they have a baby naturally. We encourage natural conception. And we're not saying this willy-nilly, it's not just random. We have the data. We have the data from several studies. I think one of the 2 big studies is the partner study, where they looked at 900 couples, mainly heterosexual couples, and they had 58,000 condomless sex acts. There was no linked transmission, linked being the important word. So they also did partner 2 studies looking at gay couples, and this was just under 800 gay couples, and they had 77,000 condomless sex acts, and there was no linked transmission. The reason I say linked is important, meaning that you couldn't link it. They were transmissions, but the transmissions happened out of the relationship. Hence the importance, as Grace said, HIV testing in ED, because probably someone didn't know they were HIV positive because they never come to a clinic. They don't feel at risk. But they do attend A&E, and they do attend primary care, and they might be somebody for the first time that comes to your GP practice. I don't think we should always say, "Oh, that person's at risk." And I know that I don't know if all surgeries do, but there's some GP surgeries that offer HIV testing to all people who are new to their GP practice. So it's about having testing in other areas will help prevent these linked transmissions happening and helping us get to 0.
Exactly. Knowing your status is so important. That's a message that we need to sort of advertise. And if you're having condomless sex with a person who doesn't know their status, that is where PrEP can come in, so that you can empower those people to protect their sexual health with something like PrEP. And and as Emily was saying, we want to try and do more testing in primary care. And if you do a test and the HIV test is negative, that is actually an opportunity for you to discuss PrEP if you're giving back that result to that person saying, oh, it's great, your HIV test is negative. However, did you know that there's something that you can use to prevent you from
Mm.
getting HIV? And it's called PrEP. So this is why PrEP is so exciting, because it's something that can really make a huge difference in
Mm.
primary prevention.
Mm. And I think all of these messages that are coming through sort of loud and clear from speaking to the two of you is that it's worth challenging our established mode of doing things. Thinking about um, testing, thinking about new patients to practice and testing them, having conversations about PrEP and understanding it well. And this really powerful message of U equals U, I think is something that we've just got to internalize and understand and believe in primary care, because I think there'll be many of our colleagues that will maybe hear that but not really believe it. But it's so great hearing it from the two of you. U equals U. Um,
Yeah, exactly. And, if we do want to reach zero new transmissions by 2030, of course, we need the emergency department testing, absolutely. But I don't think it can be done without involving primary care and
mm,
all of our primary care colleagues, because, you know, we are the we are best suited to do the routine testing in primary care. We see many patients about lots of different things. So, as primary care clinicians, we are best suited because we see many patients who have a negative HIV test, because we're not HIV specialists. So, as I said, it's a great opportunity to offer PrEP and to discuss PrEP, but also primary prevention is our bread and butter. As we said before, we know we offer statins to people, we offer diabetes prevention programs for people with raised HbA1cs. So PrEP should just be part of our routine care. And we know that one of the main barriers to ending new transmissions is stigma.
mm,
So stigma kills, essentially. And it's not just the stigma that our patients carry or that our patients face, whether they are living with HIV or whether they don't want to have an HIV test because they're worried about the stigma that they might receive. It's also the stigma within our healthcare uh, profession.
mm,
And that is a barrier that stops us from discussing HIV in the first place or offering HIV tests. Whether we think it might be a difficult conversation, or we might fear that there'll be a breakdown in our relationship with our
mm.
patients. But actually not discussing an HIV test and not discussing PrEP, we're doing our patients a disservice by not informing them of what's available. So yes, I really do think that we cannot achieve this goal that the government has set without us in primary care. I think we're just essential.
Absolutely sage words there. Having those conversations, normalizing it, making this a normal part of our practice. You'd never dream of not having a conversation with somebody about diabetes or smoking for fear of upsetting
Exactly.
them. But yeah, absolutely right. It's an emotive topic, and people need to think about how they phrase that. And I'm really glad to say we're going to do an entire podcast on language stigma, and we're gonna have get some experts in on that as well. So I'm really looking forward to talking about that and improving our confidence in primary care as well.
Absolutely, yeah, because it is all about confidence, and yeah, we're here to encourage people. We appreciate that these are difficult conversations, and sometimes we struggle because we're lacking in time. We've got lots of patients waiting. We don't want to bring up a difficult conversations when there's 5 minutes left. But the more we have them, the easier they will become. The more confident we get, and yeah, the closer we will be to reaching our target of zero new transmissions.
Excellent news to hear. Well, I mean, this has been an absolutely fascinating conversation. I have learned a huge amount about this. Emily, while we've got you, and thanks so much for your time today. If I suppose I'll finish with this. If you had just one or two things that you would want people to take away from our discussion today, what would they be? How can we help you in the GU service in primary care to really nail this as a topic?
Think of PrEP as contraception. You know, you see somebody at risk of having an unwanted pregnancy. You see someone at risk of getting HIV. Just think of it that way. It's really straightforward. Refer them to a level 3 GUM service. We're open access. We're here. This is our bread and butter. We're very happy to welcome your patients, manage the patients, and make them safe, make them well, prevent them from getting HIV. And it's free. Really, I mean, I think letting people know that it's free, they don't need to be a UK resident, or that instantly, just because I think particularly asylum seekers, they're very at risk. And you know, you all know the minute you ring somebody with an withheld number who's in this, they're not going to answer the phone, are they? So they just need to know it's open access. No one's going to ask any questions. No one's going to call the immigration on you. So that's what I'd like people to take home.
Excellent. And thank you so much, and wonderful words to finish on. Thank you so much, Emily, for your time today. It's been really great hearing your wisdom and knowing that there's so much that we can do here. And I really hope that people will use this knowledge to improve the care for their patients. And thank you so much, Grace, for helping set this up. And I really look forward to our future conversations. And we've got a couple coming up. What are we covering on those?
We will be speaking more about HIV language and stigma and sort of words to maybe avoid, and more appropriate language to use when you're talking to patients or people living with HIV.
Well, great. I really, really look forward to that. Thank you for your time today, Grace. Thank you, Emily.
Thank you for having us.
Thank you so much for having us.
Thanks. Thanks again for listening, and a huge thank you to my guests, Dr. Grace Bottoni and Dr. Emily Mabonga, for joining us. Together, we have explored how PrEP and PEP fit into the GP toolkit, how to open up conversations about risk and prevention, and why normalising these discussions is key to tackling stigma and empowering patients. We've got one final episode coming up where we're looking at the broader picture, tackling stigma and looking at language when talking about HIV. And until then, take care, and thanks again for being part of the conversation.